Good morning and welcome from Toronto, Canada. My name is Anna Sangster from the International Federation on Aging. It is my pleasure to be with you here today to bring the latest webinar in the WHO IFA Age-Friendly series entitled Engaging Older Adults in Simulation. It is a privilege this morning to be joined by Ms. Lisa Sokoloff, Manager, Training and Simulation, and Ms. Kathy Smith, Interprofessional and Simulation Educator from the Baycrest Center for Education and Knowledge Exchange in Aging. Lisa and Kathy have an infectious passion for the work they do with older adults and have been instrumental in the development and implementation of SAGE, a volunteer simulated patient program, of which we will be learning about today. Now, before we kick things off, just a couple of housekeeping notes. First, as always, the webinar recording and slides will be made available and disseminated to all registrants. Second, please ensure that all questions are submitted via the Q&A function. This allows for better coordination during the live Q&A portion of this session, and it allows for us to keep record of any unanswered questions. Now, with that said, I'll turn things over to you, Lisa.
Thank you so much, Anna, and good morning, good afternoon, good evening, depending on where you are in the world. It's our absolute pleasure to be here today, and thank you for inviting us. We can just go ahead to the conflict slide, if you don't mind, just to say that neither of us have any conflicts to declare. And I'm just going to tell you a little bit about Baycrest. Baycrest is a geriatric health system that includes a hospital, a long-term care home, a retirement home, a seniors apartment building, and multiple outpatient clinics and services. Baycrest is located in Toronto, Ontario, Canada. And I'm now going to turn things over to Kathy to kick off the talk.
Hi, everyone. So first of all, I'm just going to cover the learning objectives for this session. So by the end of this webinar, we hope you will be able to define simulation and simulated participants, describe the role of older adults in simulation to provide authenticity, and discuss applications of simulation with older adults in their work and community. And as Anna said in her lovely introduction, we really do have a passion for this. So we're hoping we can communicate that to you as well who are listening. Next, please, Anna. So first of all, we're going to start with a poll question. We're just really interested in what environment do you work? Because in our conversations with Anna, we understood that not everybody's going to be working in healthcare. So if you could take a moment, Anna, I think you need to flip over to the poll question. We'll ask you to answer one of these questions.
We'll leave this up for about a minute to let people, and then I'll release the results.
Thank you, Anna.
Not a problem. Give it another 30 seconds or so.
Okay.
And terrific. We'll end the poll there, I think. Okay. Well, sharing the results. Interestingly enough, we have quite a bit of other, so I'd be interested to know who that other is. So if you'd like to, please feel free to chat and share. For those of you that put other in the chat box, we'd love to hear kind of where you're coming from and what environment you work in. So I'll stop sharing that for now, and I'll hand things back over to you, Kathy.
Okay, thank you, Anna. And it's interesting to see that there's almost an equal number of people in healthcare and long-term care facilities. So that's, as well as municipal. So that's good for us to know. Okay, next slide, please, Anna. So we're going to step back for a second, and we're going to talk about what is simulation. So this is a classic definition. So simulation is a technique that creates a situation or environment to allow persons to experience a representation of a real event for the purpose of practice, learning, evaluation, testing, or to gain understanding of human systems or actions. And when we provide this definition to people that we work with, sometimes people will go, well, I've been doing that. I just didn't realize it was a simulation. And we're going to talk about different applications of simulation a little bit later in the presentation. Simulation is an educational tool. It can also be an assessment tool, but here we're talking about it as an educational tool. And the goal of simulation is to transfer lessons learned to real world situations because it's an expensive intervention. Even when you're working with volunteers such as we are, it takes a lot of resources, and it also takes the time of learners, their precious time. So it's really important that whatever we're trying to do in a simulation is tied to learning objectives and tied to an overall goal, which is ultimately improving patient safety. And so simulation-based education, it allows for the practice and mastery of skills and competencies associated with the care involved in working with older adults, which is even more complex because we're talking about people with a lot of complex medical situations often, and psychosocial situations, as well as teams are working together to help them. Next slide, please, Hannah. So simulation is an evidence-based practice, and there are standards of best practice. We're going to talk about those in a minute. There are also simulation phases. And here, this is a model that is adapted from a colleague in Australia, Deborah Nestel. It's a 7-step model. And you'll see at the very top at the 12 o'clock position is preparation. And really that square should be about 10 times bigger than the other squares. Preparation is key to having a safe and effective simulation event. And preparation may involve working with subject matter experts to create the scenario, develop the scenario, train the people who are going to be involved in the scenario as the simulation educators. And in our case, it's simulated participants. I'll define those in a moment. And get everybody on the same page, including the learners. So then we move into the briefing phase. And in that phase, that's where everybody is told about the logistics of the simulation just before it starts. You have the simulation activity, and then you have the debriefing phase. And that's traditionally where a lot of the learning happens in simulation. And there's a focus on reflection, helping the learners to understand and come to understanding rather than telling them. There's a reflection period for all that can happen after the simulation and the formal debriefing event. There's an evaluation phase, which is very important to think about. And then there's a de-rolling period and a debriefing period for the SPs, but also really for any simulation educators that are involved. So you can see that it's complex. There's a lot of moving parts. Next slide, please, Anna. So the basic principles of simulation are that there are strong learning objectives within the context of the curriculum. When simulation has been around for a long time, but the kind of simulation that is done now in healthcare, and for example, with SPs, SPs started working about 50 years ago, and high technology simulation where mannequins are used and or virtual simulation really started in about the last 20 years. And when it first started, there weren't standards involved and there wasn't a lot of research. So sometimes people would go, let's have a death in the simulation. And it had nothing to do with the learning objectives. And it was really traumatic for everyone involved, or it could be. So there's a real strong realization now that it's very important. Anything that's done in the simulation involves strong learning objectives. And it's also important that there are skilled facilitators who are able to apply the principles of simulation. And this, again, is not always understood. To have people that don't understand how to run a simulation or how to facilitate it can result in a psychologically or physically unsafe event, as well as not effectively achieving the goals of the simulation. It's also important that the levels of fidelity or reality are matched appropriately to both the learning objectives and the training level of learners. So it's the right fidelity for the right simulation event. Next slide, please, Anna. The simulation framework that I talked about a little bit in the models is, again, just to repeat, there's a briefing before the simulation, so everyone is operating from the same mental model of how this is going to proceed. And also other things. What happens if I blank? What happens if something goes wrong? What's plan B, C, or D? Briefing creates psychological safety for everyone involved. And psychological safety is a concept that has been uttered a lot, and it's just starting to be researched in simulation, at least. And psychological safety really refers to creating a space where people can make mistakes and ask questions, and they're not going to be judged. There's a basic assumption that was developed at the University of Massachusetts, which states, I'm paraphrasing it slightly, but it states, we believe that everyone is here to learn and has the best intentions to do so. So that is a very important mind frame that is often repeated in a briefing, so that simulation is designed, if people knew how to do it, you wouldn't need the simulation, because again, it's such an expensive intervention. So it's designed to push people a little bit past their comfort level, but not too far. The activity often is very short. It might only take 2 or 3 minutes. And then the debrief, again, is where a lot of the learning happens. And there are a lot of different models for debriefing. And again, this is where it is important that facilitators are trained carefully in how to do this. The good news is there's a lot of training tools for people to use. So there's a lot of support if you don't currently do simulation, but you want to develop it in your context. Next slide, please, Anna. So now I've been using this term, I want to formally define it. A simulated participant is a well person who is trained to portray another person. So it could be a patient, a family member, even another health professional, even learners. It's really important if an SP is portraying another health professional that they have the ability to do that. So sometimes we will recruit actual health professionals such as nurses or PSWs to play a simulated nurse or a PSW. It's also, so SPs, traditionally that acronym meant standardized patient, but the scope of what SPs do has broadened so much that this broader term is used. I also want to emphasize that almost always it's a well person. For example, if we were creating a scenario around somebody who's getting bad news, like getting news, not necessarily bad, but that perhaps that they had a diagnosis of dementia, we would not recruit somebody who had memory loss, because things could happen in the encounter. They could become personally upset, and that is not fulfilling the learning objectives. So we very carefully screen our SPs to make sure that they are able to comfortably and safely do this. I just have a question now. I'm going to answer this because it was my next talking point from Catherine. Do we recruit actors as SPs? So I want to disclose a little bit of my background. I am a professional actor and I have a PhD in drama. However, what I am doing as an SP educator is very different. There's similarities, but there are also differences. So actors can make excellent SPs as long as they are trained very carefully in their role as an SP. And the kernel of it is that actors are fulfilling the vision of the playwright, the director, the producer. They're there to entertain the audience, where an SP is in service to the educational objectives of the encounter and to the learners. And so there are very important differences. Actors can make excellent SPs, but they can make not good SPs because if they think that this is going to be their Academy Award opportunity, this is not good because it gets away from what we're asking them to do within the boundary of the semi-scripted scenario. And we can talk a little bit more about that in the question and answer as well. Next slide, please, Anna. So just a little bit more, I was talking a little bit about this, but I'll just unpack it a bit more. An SP is a proxy for the person they represent. So authenticity is very important. And it's almost like there's a sacred trust to represent that patient's perspective in the encounter, because they are the only person that can do that. And that is huge educational value. At the same time, what they do has to be standardized along a spectrum. So they may have a standardized opening line, or there's certain details that they can provide, but not other details. So we're not going to get into great detail in that in this session, but they are carefully trained. As I mentioned, and it's worth repeating, they are part of the educational team, and they are in service to the educational objectives and learners. And the great thing is they can calibrate their performance and they can provide feedback from their perspective. Next slide, please, Anna. So as I noted earlier, the scope of practice is ever expanding. They started about 50 years ago in medical education, and now they're working in many different fields, including the ones listed here, such as law enforcement, human resources, architecture, design, mediation, military chaplaincy, also the military, and there may be other applications that people on this call know of as well. Next, please. And there, as well as models, there's the standards of best practice for human role players in simulation. This is an open source document. You can download it, but it is the only one now, and it's used in conjunction with other standards. And you will see in the center of the circle are values, and around the edge of the circle are the 5 domains. I won't go into those in great detail right now, but I will emphasize safety is huge because there's an ethical imperative because we're working with human beings. Next slide, please, Anna. I alluded to this a bit. The characteristics of an effective SP are based on their ability, their suitability, and their credibility. So it really comes down to the right person for the right situation. Not all SPs can do all work, and that's okay. And at Baycrest, that is our mantra, and we will do our best to find people the work that's suitable to them. And I'm not going to go into detail about that, but if you have questions about that, we can talk about that in the question and answer. Next slide, please, Anna. So why do we engage older adults as SPs rather than young people dressed up as older people, which is the practice, the reported practice in some places? Well, at the kernel of it, it can be ageist and create stigma by having young people put on gray wigs or talk in, I'm putting this in air quotes, but hopefully you can hear it in my voice, old people voices, or behave in a stereotyped way. It takes away from the authenticity. And one of our colleagues has done some research, Namat Al-Saba, and she's quoted in the references. She did some research around working with mannequins, which we'll have a picture of in a second, versus older SPs. And the learners were much more engaged with the older SPs because they provide an authenticity and an integrity that can't be matched by young people doing it or by having mechanical bodies there. Next slide, please, Anna. And we have done some research. So I have a colleague, I'm not sure if she can get into Zoom here. I think she sent me a note, but Claudia Schlegel in Switzerland, we did through Baycrest, we did some research with her, as well as we've done another article around a framework that Lisa's going to talk about. And there's a colleague in Britain who's done some research, but the older SPs identify great benefits to their well-being, which aligns with greater literature about what is well-being for older adults. And this includes all these bullet points that you can see. I just want to highlight just a couple of them, by really feeling a sense of purpose and contribution, appreciating opportunities to transform their personal experiences into something meaningful for learners, social connection, personal growth, great enjoyment, and the feeling valued, which was really helpful information for us to get as well, and validating for the work that we're doing. Next slide, please. And the work they're doing. So again, just alluding to mannequins, which are mechanical bodies, which have varying degrees of physiological function. And you can see the one on the left is less realistic, perhaps, or has less fidelity than the mannequin on the right. And they're appropriate to use when the learning objectives support that. However, think about if the learning objectives are about interprofessional communication or interpersonal communication, and often they're voiced by someone. There's great voice programs now, but it's very different when a learner says, "How are you today, Mrs. Smith?" And the mannequin, you hear a disembodied voice from a mannequin, "I am fine, thank you," versus, "Oh, I'm okay, thanks," from a real human being. So again, I want to emphasize that it's not a binary thing, but increasingly there's a realization that if mannequins can be used, or if SPs can be used when the learning objectives support it, there's great value in that. Next slide, please, Anna. And the types of scenarios, there's some questions coming up. We'll look at those at the end because Lisa has a little bit and we just want to make sure we get through it. Really great questions. So types of scenarios we use are ones in our environment. So discharge planning, acute care changes, engaging families in care, screening for depression, and so on. We use a motto. We stumbled upon this. We have in-person encounters, but we also use what we call trigger videos, and where our SPs, Anna, can you just forward the slide? Yes, so the type of roles, I'll get to those in a sec, the trigger videos, but the type of roles are family members, healthcare professionals, residents, and patients, of course. And can you forward the slide again, Anna? So I'm going to show you, I alluded to this, it's a trigger video just before you started, Anna. So they're short bursts of the kind of key learning objectives that can serve as a jumping off point for discussion. So someone just put in the question or the chat line, what do you do if you don't have a budget? So this is one of the ways, because we work with volunteer SPs, and we don't have a huge budget, but this is a way to leverage a lot of our resources. So what you are going to see now is a trigger video around one of what we call the 8 A's of Alzheimer's, and it's around amnesia, one of the symptoms, amnesia. And so the idea is in an in-person workshop or online learning that we do a lot of, we would show this, and then the video would serve as a jumping off point for a discussion about this. I want to apologize in advance. The video, the sound's good, but the video is going to be a little bit of a choppy just because of the interface with technology, but we think that you'll get a really good sense of it. So take it away, Anna.
Okay, Mom, I'm going to go now. All right, but I'm coming back in 2 days on Sunday, okay?
Okay.
Bye.
Okay.
Lisa. Nancy, hi. You must have had a great visit with your daughter.
My daughter? She hasn't been here this week.
Thank you, Kathy, and thanks for giving that great overview of simulation. I'm going to talk a little bit now about our program stage, and then I'm going to broaden things outside of healthcare And I'm excited. Thank you for filling in the poll about some of the other areas in which you work. So, and I also want to say most of the pictures that you're seeing are of our SPs, and we do have permission to share them with you. This happens to be one of a Zoom call because during the pandemic, this is what we are doing. We are still connecting with them all weekly over Zoom. So SAGE stands for Simulation Activities for Gerontological Education. The program at Baycrest is a collaboration between the Center for Education and Volunteer Services. Our SPs are volunteers who are primarily older adults. We actually even have one of the volunteers SP as part of our administrative team working as a coordinator. The volunteers are trained and skilled, and they bring significant life and work experience to their roles. Have the next slide, please. So as Kathy has mentioned, with SAGE, as with any SP program, it's really about the educational process and providing service to the learners. And this can also work outside of healthcare that we'll talk to, because it just really depends on what your learning objectives are. If your learning objectives are related to designing a building or designing a program in an age-friendly way, that the SPs can be trained to do things to meet that specific learning objective. Okay, we're going to go to the next slide and hold our breath and hope that the sound works. Now, this is just a sample of a video that is designed as part of our annual training, our Code Red. And you'll see that we've enlisted not just our SPs, but also some younger volunteers and staff pulled in to help support, fill in some roles. So let's see if this works. Go ahead, Anna.
Shirley, it's showing code red in room 4. Call 5555 and report the fire. I'm going to check room 4 right away.
Code phone, what's your emergency?
There's a fire alarm on Hospital 3 West, room 4.
Code red, so Hospital 3 West, room 4?
Yes.
Thank you.
Thank you.
Code red, Hospital 3 West, room 4. Code red, Hospital 3 West, room 4. Code red.
Mr. Cohen, please just head towards the nursing station and wait there, okay? Thank you. Mrs. Green, it looks like there might be a fire in the washroom. I'm just going to get you out and bring you to somewhere safe, okay?
Okay, thank you.
And we can stop the video there. We need to go to the end of it.
Hello, 911.
And actually, if it's okay, can we go back a few slides and just show that the trigger video again?
Absolutely.
That one, yeah.
Yep. Trying to get all of it.
So as Kathy mentioned, this would be a video that we would show. We use it in different contexts, but it would stimulate a discussion around one of the 8 A's, or the common features of dementia.
Okay, Mom. I'm going to go now. All right, but I'm coming back in 2 days on Sunday, okay?
Okay.
Bye.
Okay.
Lisa. Nancy, hi. You must have had a great visit with your daughter.
My daughter? She hasn't been here this week.
Now, I'm not going to ask you to guess which of the common features of dementia that just was, but just to give you an idea. And we will talk about budget, but just so you know, that's just filmed in the hallway outside our office. So you don't have to go to fancy production studios and things either. I'm going to speak now about special considerations when working with older adults, whether you're working with them in a context outside of simulation, but also specifically around simulation in SPs. There can be unique considerations when you're working with older SPs and older adults that are related to physiological changes that are associated with normal aging. And these include physical, sensory, and cognitive functions. Although the changes may not be significantly affected in all older adults, they may influence the performance of some older SPs. And those who work with SPs may not be clinical experts in the care of older adults and might need some guidance in how to recognize, understand, and accommodate for the potential changes in older SPs. I could have the next slide, please. We developed a collaborative framework, Kathy, myself, and our colleague, Dr. Namata Salva in Australia, with accompanying strategies to guide people who are working with older SPs, no matter what their level of experience or degree of resources. As well as considering physiological changes in older adults, the framework is informed by existing simulation best practices. And we do plan in the future to do another webinar where we will discuss more about this. But it is the reference to the article that we published is in our references. The next slide, please. Oh, there should be in their own word. There we go. Thank you. I'm so glad the video is working now in the audio because we've been talking a bit about this. And one of the best things for Kathy and myself is how our SPs feel about this. And as older adults, they feel valued and appreciated. So we wanted to share with you what they have to say about it. Sorry, if you go back to in their own words, there should be a video on there. It's just a white screen. Sorry.
There we go.
I was learning things I'd never even thought of. I met some wonderful people, lots of fun.
The different vignettes in SAGE really help give a picture of the different experiences and different programs at Baycrest. And meeting the other SAGE volunteers and how rich each person's life is and what each person brings has been just, it's been wonderful being part of that.
It's something that is being used as a teaching tool. That alone is enough.
I think that I get so much out of it. It's supposed to be me contributing something to SAGE, but what really happens is, besides that, I get a lot out of it. And I do enjoy it. And when I leave after every scenario that we've done, I always feel good. You know, I come out happy and you know, glad that I had a chance to do that.
You want to do something meaningful in your life? Do you want to have fun? Do you want to feel your self-worth? You know, come join us. We're a good group, and we're helping the next generation, you know, to learn how to deal with medical problems better.
You get to play. A little bit of you comes out, and it's fun.
Thank you, Anna. We can probably stop the video there. A quick note about budget. That video was put together by a summer student. So it was a very, very low budget kind of thing. I'm going to switch gears a little bit now. And in this next section, we really want to talk about applying what we've talked about today. So applying the knowledge sharing. I'm just looking back from the poll things. There were some people work in healthcare on the call, some who work in healthcare, specifically long-term care or retirement home, some people from education, people who are older adult advocates or advocates for older adults working with the United Nations on behalf of IFA, and people working in municipal and government. And so that's great. And I'm hoping that we can have some discussion around this after. But And I know that many of you, when you are working, designing on your projects and programs, you're going to include older adults on your advisory boards and or consult with them when you are designing things. And as important as that is, I just want to say it's still not the same as actually engaging the older adults in simulating scenarios related to your projects. It's important, it needs to be done, but the simulation with older adults takes it one step further. An opinion is not the same as walking through the process. So you may have heard the term universal design, which basically means creating and developing to meet people's needs. And we would like to suggest that if you design with and for older adults, you will actually be designing for most other groups. Now, the next slide, please. Now, having said that, in some cases, it is appropriate to engage others to build empathy. Here are some pictures of people wearing what we call an aging simulation suit. That's my son in the green one. He gave me permission to use this. We use these suits with young, healthy adults to simulate some of the cognitive, physical, and sensory changes that older adults may face. For example, we've had them put on the suits, which also include earplugs and goggles. You see that affect their vision, gloves on their hands that affect their sensation. We've had them do things, run through scenarios like trying to withdraw money at a bank, walking down really long hallways of an apartment building with nowhere to rest, or trying to open heavy doors. Next slide, please. So I want you to look at this and ask yourself, would you walk on this carpet? And what if you had visual spatial issues or cognitive impairment? And I want to share with you that this is a brand new carpet that was just installed in the hallway of the condo where my 85-year-old mother lives. She does not have significant visual spatial or cognitive issues, but she tells me that sometimes she finds it challenging to walk down the hallway straight, that she finds herself sort of wavering because it's almost like an optical illusion. And so I asked her, how did they decide on this carpet? So, well, there was a committee of people and they had, swatches up on the wall and people voted. And it made me think, a swatch on the wall is one thing, but what if they had taken a big piece of that carpet, rolled it down the hall, and had people try and walk on it and give their feedback? So it's just something to think about. If I could have the next slide, please. So I previously mentioned the aging suit simulation, and I want to take a moment before we discuss openly to share some non-healthcare simulations that we've run with some different industries, and then give you some quotes from what people who participated in these who are not in healthcare, how they felt about it. So one thing we did was we worked with the National Bank with their marketing staff to have them better appreciate some of the challenges that older adults may encounter, including things like the font size in their brochures, how high up on the wall things are placed where you go in to pick up a brochure, where things are stored, and access to things like ATMs and PIN pads. We've worked with a couple of different companies in different countries in Asia who are designing and developing residences for older adults and are trying to make them age-friendly. And prior to participating in the simulations, they didn't even really think to consider things like the color of the walls, how the furniture was placed, what the furniture looked like, the length of the hallways without somewhere to sit and rest, things like that. All important things for an age-friendly setting. We worked with industrial design students who were developing products for older adults, but hadn't necessarily considered the physical and sensory changes that can happen with aging. And the 4 points that we have up there are some of the things that they noted. So aging in place, some of the participants told us that they recognized they needed to be more interested in functionality. So when they're designing a room or a space for older adults, is it good enough now? They can walk through maybe unassisted or with a cane, but what about if they need a walker? What about if then they need a wheelchair? Can they still participate? Can they still attend? Will they fit through the doorway? Also, the concept about universal design that I mentioned earlier. And one of the companies mentioned to us who's designing the residence, we're going to have to take a different marketing approach. We can't just make brochures and things. We actually need to have something physical that people can come in, like a showroom where they can see the amenities and give their feedback about it. As far as increased empathy, it was really moving to me to hear some people, this was actually a designer who works with colors and things, and said, we don't live here. This was, again, designing one of the residences. We need to take their perspective into account. And it was very eye-opening to help me understand what some of our elderly customers are managing, with what they're trying to manage. And then again, the consideration of the things that can happen just with normal aging. So even things like considering the design of how steps are, what's the color, is there good contrast? Are things white on white, or is there a color gradation so that they can see depth perception better? Are things easy to reach? And people commenting too about, it would be great, we understand it would be a good idea to use pictures, because again, even though you're designing perhaps for older adults, that would also address any issues around languages, other languages other than the language in which you are, the country in which you are living. That did not come out well, but I think you understand what I mean. So I'm going to invite Kathy to turn on her camera and her microphone with me as we go into the last little bit. And Anna, if you don't mind going to the next slide. We did, with our learning objectives, one of the things we should have asked you was to think a bit about anything you particularly wanted to get out of this. And so I'm hoping we can have a bit of discussion. We have gone through our learning objectives, but to see if the objectives met what you were participating, met what you wanted to get out of this. And we're happy to answer any questions. I'm going to ask Anna to go to the next slide, because this is something we'd like to talk a bit about in the discussion. But first, if people want to put questions in the Q&A, we can start with that while you're thinking about this. And these are things you can put in the, Anna, would it be okay for them to answer this one in the chat? What's something they're taking?
Absolutely. Any of these questions, please feel free to add your answers to the chat, and we'll we can call upon you, or we can just have a discussion around those answers as well. So if we want to start, Lisa and Kathy, with just, I know that there's one question currently in the Q&A about budget, and we've touched on it briefly as we've kind of gone through the presentation, but I did want to provide you guys the opportunity to expand on that if you'd like, and give you a few minutes to talk to that.
Sure. So Kathy, do you want me to?
Sure, if you want to start. And
sure. We do this all the time. We'll just jump in and on each other, and that's okay. So regarding budgets, Kathy mentioned there are ways to do things that are not as expensive, but you still need to maintain high quality if you want to have value with what you're doing. So, just saying to someone, well, you just put on a wig, or if Kathy said to me, just pretend you're 90 years old, you're going to lose a lot of authenticity in that. So one of the things that we do use or work with are volunteers. There are many SP programs where people are paid, but we never want people to think that just because it's volunteer, there's no cost associated. So we do to pay for people to help set up the framework or the structure. So one thing that could be done is, for example, partnering with someone in your area where you are living or working, and see if they have a program already in existence. We do that. As I said, we go out to other places to do that. Another thing is to, as Kathy mentioned, is the trigger videos. So doing things in such a way where maybe there's a little bit of outlay money in the beginning, but it's something then that you can use. I can tell you that hundreds of times that we've used those videos. So the return on investment for a very small amount of money to do the videos, you couldn't really see the quality of them as well, because again, with all the technology things going on, they were a little bit choppy, but they look fantastic when they are really being used. And we use them in our e-learning modules for staff. We use them when we're doing training, things like that. Kathy, did you want to add?
Yeah, I don't want to be negative. I want to say, however, so we have this amazing volunteer. We work with volunteers because SPs can also be paid, and there are many older SPs who are paid. In our context, the majority of them are volunteers. And sometimes people think, oh, volunteers, that's not going to cost any money. There still is an outlay of resources. If you can leverage with another facility, that's great. Our SPs are as carefully trained as those who are paid, and we had to invest time to create the infrastructure so that they understood their role and responsibilities and also how they work as an SP. However, you can still leverage it. So one thing that I would recommend, not to be self-promotional, but only because there really isn't a lot out there so far, is the ASPE standards of best practice. And then if you look at the framework that we noted, because one of the reasons for us writing this article was to give people some very practical strategies to operationalize. It's also very important that whoever is leading the SP program understands basic concepts about simulation and how to facilitate. And I go back to psychological safety and effectiveness of the intervention. And you can do it in baby steps because that's also how we started to do it as well. So it's not all or nothing. And there are resources out there for you. And again, we'd be happy if you take a look at those and you have further questions because it's also contextual, but there are ways to do it when you don't have a lot of resources to leverage your resources optimally.
And we're always happy for people to reach out to us after if you want some support. I see there's a second question or nothing about it.
There is. Olive has submitted a question, a really great question. How do you convince policymakers to embrace this concept for older adults?
Yeah, isn't that the question of all questions, right?
It is indeed. I saw you both have the reaction, yes.
But it's so true though, right? And I think that, correct me if I'm wrong, but I would imagine, as I mentioned, many of you are already using is the wrong word, engaging older adults as people who want to give opinions and be on committees and things. It's really about return on investment, I guess. And it's part of it is the advocacy. And I would actually maybe even ask there's a couple of people on the call who are advocates for older adults. And I don't know if that's something, but one of the things you can talk about is waste of money. So let's say, for example, you're designing a space, a building, and it's supposed to be an age-friendly building. If you don't engage older adults in it, and then something comes up later, maybe you've lost a lot of money. And I can give you an example of something that happened recently in a hospital. In the last 10 years in a hospital here in Toronto, where a colleague of mine was actually telling me the story that they were designing a new wing and it was going to be beautiful and everything was great. And there was a pillar in the middle that they thought, that's great because we'll put some private beds behind there and whatnot. And they built it. They didn't do any sort of role playing or simulation of it. And then when the nurses got in and sat down at the nursing station, they said, I can't see any of the patients behind the pillar. So all of a sudden they had all this wasted space. So I think that's one way to do it, is to talk about the benefits that you will get from having this sort of input up front. Kathy, is there anything you wanted to add?
Well, I just wanted to add as well, just to go back to our situation. One of the reasons why I reacted like I did, I feel so lucky to be at Baycrest because that's built in. That is part of the ethical value system of the organization, that this program wouldn't be developed without the SPs and their input. And there's a very strong volunteer program at Baycrest. So again, if you're thinking about trying to create a program like this to leverage the advocacy and the resources that are already in place, can be a pretty powerful tool. It has been for us.
Thanks, Kathy and Lisa. We have another great question in the Q&A box right now. Can you comment on the challenges of helping older adults who have no cognitive problems to simulate a person with dementia?
Do you want me, Kathy, or do you want to?
Well, I'm just wondering so talking about a simulation scenario, so how we would work, we have a template and we help subject matter experts to develop a scenario, which is semi-scripted. And so typically it would include affects that would be needed, and they would be very, very carefully calibrated. So we would work with that subject matter expert to shape the role. And then we might even make a training video. But before we even get to working with SPs, we would have that very clearly established. And also either Lisa or myself, I would often step into role to make sure that I can get it into my body and I can explain it to the SPs, or Lisa can. So there would never be a situation where a faculty member or a clinician called on Monday morning and said, can you send somebody down to play a dementia role tomorrow? Well, there has been, but it doesn't. We've had to, that's part of setting up the infrastructure, because first of all, that also brings into play that the older adults have to be very carefully screened to make sure that they are comfortable with this role, because some of them, if they're not experiencing that, they have family members, and our research shows that some people do not want to do it, but some people feel, as I mentioned earlier, they're in great service. So this is where screening comes in as well.
We also say that we rehearse a lot, and like any role, whether it's dementia, whether it's anything else, as Kathy mentioned, we really get to the nitty gritty with the subject matter experts. What are their facial expressions? What words are they using? Are they moving their body at all? Are they just sitting? And then we craft that and we practice and we rehearse. And we often have the SPs practice with each other, with us there. And then we'll all get together and they'll also give us feedback. You know, it doesn't, if we say, do this, it doesn't feel right to do that. This is what I think. And then we'll work it all out together as we workshop it. So it really, I mean, the question asked, well, what were the challenges? And I don't think there have been real challenges. We've actually been quite successful with our SPs who do not have cognitive impairment, who are willing to play those roles.
And I think if there are any challenges, and I wouldn't even want to frame it like that, but it's the helping the subject matter expert to articulate the role and creating the role. I also want to say that a potential challenge, this is why the briefing and debriefing is so important. But even if somebody's carefully screened, something can come up for them that can be traumatizing. And so that's why the debriefing and the de-rolling is so important. So you can see when we look at that simulation model, that circle, the preparation phase is huge, because you really need to get all your ducks in a row before you go into the simulation to ensure that it's going to be safe and effective.
Thanks, Kathy. I think we'll probably have time for one more question, and I think I'll dovetail off of what you were just saying. And you've talked a lot about kind of finding the right fit and the right fidelity. Can you speak a little bit about kind of your recruitment process and what that looks like, and kind of, you know, the typical duration of training and things like that?
Do you want to? Okay.
So we have a very, when we first started, the program was starting as a pilot before Kathy and I got here. And so when we came in, we realized that infrastructure was missing. And so we have an orientation, a 1-hour orientation, where anyone who's interested, so when new volunteers come, they're told this is an opportunity. So we get them together, we do an orientation, and we talk a bit about some of the similars, like what is simulation, what's CSP. We ask people, you know, why they want to do it. And we talk about a lot of the things we spoke about today. If they choose to come back to the next session, we have a 3-hour orientation, which we found works much better broken into 2 90-minute blocks. And in that, we do a lot of practice and role playing, and we actually have a whole flow chart of what happens. And if for the most part, most of the people who go through the orientation are good to continue on with the program. Sometimes some of them need some extra work with Kathy, and so that will happen. We have had some people where they've said, you know, this isn't for me. And we've had some people where once they've been in the program, I've checked, the worst thing in the world is to have to fire a volunteer. But we had people who took it upon themselves that it wasn't about being in service to learn, it was all about them trying to fix the system, and that just didn't fit and it wasn't safe. So we encourage them to do other volunteer activities. But we do have a very structured system that, again, if someone is just interested in, they can contact us and we're happy to talk about that. There is a quick question about volunteerism and paying older adults. We do sometimes pay for our SPs. We have a bit of a hybrid program. When we do, they are external SPs, and generally it's for a role when there's a lot of memorizing required or a lot of affect that needs to be finely tuned. And Kathy is well connected with the SP world here in Toronto. So we do that, and sometimes we will pay for some younger, for example, when Kathy said we need someone who is a nurse, but who is also an SP, because the words will flow better, the way that they move just fits in with the role of a nurse, so we will pay for that. But I will tell you, sorry, and Kathy, I know you want to jump in, but our volunteers will tell you in SAGE, they don't care that they're not paid for it. They get so much out of it. Kathy, you look like you want to say something.
Well, I was going to say, and it's also, it is, they are doing this in service. So they are not, they don't, like, they don't want to be, like, they're not there to be paid. This is part of their payback. And many of them also have like 5 or 6 other volunteer jobs. And it's been interesting because when we do bring in the SPs, the paid SPs, there's no acrimony, like there's no social imbalance, because they have made this choice at this part of their life that they wish to be volunteers. You are bringing up a very important point, though, that it is very important to get that straight up front and to make sure that you've screened, like if you are working with volunteers, it's because they're at choice, not because they think this might be a leg in to get paid, because that does happen at other larger SP programs. And it's a large question.
Sorry, I was also just going to add that even though we don't pay them in dollars, we pay them in acknowledgement and praise. And we have a couple parties during the year, and when it's not COVID and we can get together, and I think they value that as much as monetary.
Yeah, there's a research paper that many of them were involved in before we started SAGE. I believe we've got it in the references, the Bravo. I'm not sure, maybe we don't, but this was a 5-year research project, and it's what motivates older volunteers, and all of the markers of what or the findings of that research are replicated in the research that we have done as well. So nobody is being coerced to work or working there as a volunteer. And I think, as I said, I think that's important. And also kudos to the amazing volunteer program at Baycrest, because it's provided such a strong foundation, and they're strong partners in the work we do as well.
So Anna, maybe you could put up the last slide that has our contact information. We're always happy for people to email us or follow us on Twitter. And it's 10 o'clock, and we're probably going to get kicked off now. So thank you very much for the opportunity, and we look forward to coming back another time and expanding.
And a big thank you to Lisa and Kathy for joining us today, and everyone for sticking around during our technical issues. We will see you next time. Thank you so much.